because you have divided your posterior cricoid, and then if you try to put your stitches inside, you will never be able to put it correctly. So the trick is to take a skin hook again, and since it's fully divided, you can really rotate completely half of the cricoid, because it's divided anteriorly and posteriorly, and so it's presenting almost horizontally, and then you can put your stitch nicely like this. This is a trick. Some of the doctors that I know, they were looking for very, very small needles to do this down, but you can rotate completely. Not only you present something that is vertical, you present it horizontally, so it's easy to put your stitch, plus it comes close to you. You don't have to work in a hole, you work on the surface. Okay?
Does it differ the size of the suture used? Does it differ the size used in the suture?
For the sutures, usually we use 4-0 vicryl. Depending if it's a newborn, perhaps you can use also 5, but usually 4 is the best that we use, yes.
Is there a special instrument for carving your graft, or just a scalpel?
Well, when you're carving, so the measurement that you make, so I will go back to show you this a bit better. For instance, here, so the measurement that you make, you have divided the cricoid plate. So from the top of the cricoid plate to here, you make a measurement, and you say, okay, in an adult it's about 2 centimeters. In a child it will be like 1.5 centimeters. And when you harvest your cartilage graft from the rib, then this distance will be sufficient. And then we talked about the width, and then you create your flanges. If you want to create the flanges, you have slightly to undermine below the divided portion of the cricoid, so that your flanges will go underneath this cartilage. Another point that I did not mention, but you will not be able to practice or just for fun, is when you have a posterior glottic stenosis, the interarytenoid muscle, the muscle that is between the arytenoids. You keep the mucosa over this muscle, but from underneath, you probably saw that I did yesterday in the surgery. You use a bipolar and the scissors, and you try to cut this muscle completely. I have seen cases where they did put a very nice graft here, but they didn't cut the interarytenoid muscle, and they were so disappointed because there was still a posterior glottic stenosis that was not at the level of the cartilage, but that was at the level of the interarytenoid muscle. So it's very important to do this well. This is such an example where we did put a posterior graft and an anterior graft. Why did we use the LT bone here? It's not so much to keep this posterior part expanded, because you could even do this with the normal Montgomery T-tube, but it's to restore a nice anterior commissure. And you see that now the vocal cords here, they are reaching really the anterior commissure. And this girl, I don't have the sound here, but this girl, she is singing. So she has really a very good result with a nice subglottic airway. By the way, you see that at the level of the tracheostoma, you still have a suprastomal granulation tissue, which is extremely frequent in these kids. Single stage LTR. The required condition to do a single stage is when your patient has no severe comorbidity or congenital anomalies. The stenosis must involve only one airway level. It's usually a purely posterior glottic stenosis or fusion of the vocal cord, either acquired, but when usually it's acquired, it's combined with the subglottic stenosis. The tracheostoma must be close to the subglottic stenosis, because otherwise your graft will be extremely long, or your patient doesn't have a tracheostoma right from the beginning. You try to avoid a full laryngofissure because it's only expansion of the posterior cricoid, and you keep your child intubated for not 14 days, I would say just about a week in the ICU, and then you can extubate him. It depends on the age of the child. If you have an 8-year-old child, you can certainly do a single stage even without stenting.
For such cases, if I have to do extubation, I take the patient to the OR and examine, and check it's okay, or extubate in the ICU.
No, when you have, if you keep the tracheostomy, without a tracheostomy. Well, it depends on your facilities at your hospital, but it's certainly wise to keep the child under 24-hour surveillance. Someone should be around. I mean, he will not become dyspneic in a few seconds, you know. It will come slowly, but you need to have someone watching for your child during the night, at least on the first night, to see how everything is progressing. So when you do the single stage in a child who had a tracheostomy, the carving of your anterior graft is slightly different because you round shape the distal part so that it can accommodate nicely the shape of your tracheostoma. And you see that here you should not transect the anterior commissure because you don't want. This is a common mistake that is made. The people, they do a full laryngofissure. If you do a full laryngofissure, before you put your anterior graft, you should always reposition the anterior commissure by a stitch. So you close your laryngofissure from cranial to caudal up to the level of the anterior commissure. And the first stitch that you place is always at the level of the vocal cord, so you're sure that both vocal cords are at the same level. I have seen cases where the vocal cords were not at the same level, and you can imagine that the voice is terrible. So then you include the tracheostoma in your anterior graft, and you suture the graft. So, as I said, the laryngofissure is including the tracheostoma. The cartilage graft is shaped a bit different. In a triangular fashion, it's more round shaped on the lower part and more at an angle here to adapt the subglottic space. You don't do a full laryngofissure, and the indication is best for anterior costal cartilage graft or a posterior costal cartilage alone. It can also be used for a combined anterior and posterior, but usually single stage. If you do this, it means that your child is already much older.
This is Professor Mohammed Hantira, the Dean of our university. Professor Philippe Monnier.
We can talk after the lecture.
No, look at this.
I'm sorry to come
محمد حنتيرة ده conclusion. تعال اقعد دقيقة بس. تعال اقعد دقيقة ثانية في conclusion slide.
So the laryngotracheal reconstruction for laryngotracheal stenosis are useful whenever there is glottic involvement. So remember this, cricotracheal resection will never resolve the problem of isolated posterior glottic stenosis, vocal fold webbing or synechia of the vocal cord, or a glottosubglottic stenosis, but usually this is with a mild subglottic stenosis. When the subglottic stenosis is very severe, then we favor the extended cricotracheal resection that you have seen in the operation yesterday. And this is sometimes, unfortunately, the ultimate solution when resection anastomosis is not possible anymore because the patient had several failed cricotracheal resection. There is no residual trachea to do another resection, and if you can have an adequate stent, it does help a lot. So really, the LT mold improved our result, especially when we need to restore a sharp anterior commissure. So we'll practice all this on the lab, and I will come and see what you are doing and give you advices of how to do this. Plus, we'll do a demonstration here after this presentation. Thank you very much.